So what are the anatomic associated lesions with L-transposition? Well, you can think of them as the most common lesions in general, congenital heart disease. So an ASD, very common. VSD, very common. Pulmonary stenosis, very common. In fact, the combination L-transposition with VSD and PS is one of the most common things that we see. Now think about that. What is L-transposition, pulmonary artery coming off the LV, pulmonary stenosis? I can't erase, but let's just say we have a big VSD here. What's that act like? Tetralogy flow. It's the same thing. This heart doesn't care that the left ventricle is on the right and the right ventricle is on the left. So this acts very much like tetralogy flow. And in general, how do you fix this? The same as you would tetralogy flow. If you're going to keep the ventricles where they are in space connected to what they were connected to when the child was born. Now, why do we care? We care because of the long-term consequences of a right ventricle that is pumping to the systemic circulation. This goes back to your question. Which is that we know that over decades, not like years and 15 years, like decades, this right ventricle and mostly this tricuspid valve are not made to pump to the systemic circulation forever. Now, in those people that you never know who don't have other types of heart defects, you don't know, they could live forever and they might not have this problem. But in the ones that come to us, which usually have something like VSD or PS, we know that if you follow those kids forever, that the right ventricle tends to fail. Because the right ventricle is not meant to be a thick LV that pumps to your aorta all your life. And that's what it looks like. It gets very thick and hypertrophied. This thing gets really thinned out. It looks like a right ventricle because it's pumping to the lungs, right? Also, this tricuspid valve, the tricuspid valve is so-called tricuspid valve because it's got certain attachments. Those attachments happen to be to the septum of between the two ventricles. And so as this right ventricle changes its anatomic shape to look more like a left ventricle, it actually affects the tricuspid valve function. So the tricuspid valve tends to leak. So tricuspid regurgitation is very common. In addition, in L-transposition, one of the other types of lesions that we have is an abnormal tricuspid valve. Some people call it an ebstenoid tricuspid valve because it's kind of like Epstein's, but it's not the same. It's only ebstenoid because it actually is lower down in the right ventricle than a normal tricuspid valve would be. And it leaks more. So people use that term. But just think of it as an abnormal tricuspid valve that leaks. It's not that it's stenosis, it's leaking. So with the idea that the right ventricle is not meant to be the systemic pumping chamber for 70, 80, 90 years, and that tricuspid valve is going to be functioning abnormally in the systemic circulation and will leak, those are the problems we're trying to prevent long term. But you could, in theory, fix this by fixing the PS and closing the hole and leaving the right ventricle on that side. Or if you just had a VSD, by closing the hole. But you haven't fixed the fundamental problem of having a systemic right ventricle, systemic Epstein's valve, systemic tricuspid valve. So that's what we're trying to fix. Now, what that does is it changes your decision making tremendously. Because to fix this requires what? How do you fix this now when you have this kind of screwy arrangement with the right ventricle on the left, right atrium's on the right, pulmonary arteries on the right? So what do? You do some sort of what we call double switch. And the double switch is just what it sounds like, which is that you need to somehow or other route the pulmonary venous pink blood across a VSD to the left ventricle. So now the pink blood's going to what you want to be your systemic ventricle, your left ventricle. And then the blue blood will go around that and bring the SVC and IVC flow to the right ventricle through the tricuspid valve. But you can't stop there. That's an atrial switch. All that will do is now take the blue blood to the right ventricle going out to the aorta, which is not a very good idea. So what you need to do is you now need to cut off the aorta and the pulmonary artery and do an arterial switch. So you do a double switch, an atrial level switch, a setting, so-called, and an arterial switch. But you can't do an arterial switch if you have pulmonary stenosis, because you can't use the pulmonary valve. So instead of cutting those off and doing an arterial switch, what you do, and you can only do this in a patient with a VSD, is you patch the VSD closed. I'm sorry, I went the wrong way. Patch the VSD closed from the LV to the aorta. Now you have the pink blood coming, your left atrium, LV, and out through the VSD to your aorta. You can't use the pulmonary valve, so you do a conduit. RV to PA conduit.
It's a lot.
It's a lot.
So do you have a
Right?
systemic valve then?
You have a systemic valve, and what you have.
So your LV pumping.
Your LV's
through
pumping
VSD.
across your VSD. It's going out to your aorta.
So you just have your aortic.
Your aortic valve's all you need there,
Yeah,
right?
that's true.
Because your mitral valve, LV, out to
Yeah,
your aorta.
okay.
But as I patch this towards, and I use blue, that's why I got confused, but as I patch it towards the aorta, I am having a little bit more narrowed area here. And it's defined by how big the VSD is, right? If the VSD is small, it's going to be a small tunnel. And I'm stealing from the right ventricle. So the right ventricle doesn't have as much space as it had before. And then I'm taking a big honking tube, which I'm cutting on the right ventricle, and I'm patching it, God knows where, to the PAs, wherever they're located. And now I've gotten normal blood flow patterns. So we say, well, that's a win. Because now in theory, your left ventricle is your systemic ventricle, your mitral valve is your systemic inlet valve, you're pumping out to your aorta, pink blood's going where the pink blood needs to go, blue blood's going where the blue blood needs to go. It's a heck of a lot of surgery. There are suture lines everywhere. Every chamber has been cut upon. Every pathway has potential for narrowing. It's a big, big operation. A lot of surgeons don't do this operation. It's so complicated. Okay, we do. With the double switch itself, i.e. when you don't have PS, you're doing it Senning, and you're doing an arterial switch, our long-term results have been excellent. If you have anything else like pulmonary stenosis, our long-term results have been very good, but not as good as if you did a double switch. So to have to do a Rastelli is another risk factor for a poor outcome. That's in our own patient population. Those results have been published by Michael Gaze and Eric Devaney in 2 separate publications a couple of years ago. So, but I mean, just look at this, just the way we've drawn it. I mean, imagine trying to suture all this stuff into place. Now, what are you doing it for? Remember, you're doing it for that 30, 40, 50-year-old. You're not doing it for the 3-year-old and 5-year-old. So, now we come back to decision making. So why do you want to do this? Well, because we know this ventricle is going to give out. But there are other options. You could transplant that person in 20, 30, or 40, right? So you could do that. And it's certainly easier to just close the VSD or just do the tetralogy flow type repair. We do that all the time. The other problem you run into, though, besides the anatomic abnormalities of the tricuspid valve, is these patients are much more prone to arrhythmias. And the most common arrhythmia that they're prone to is complete heart block. And they develop at any time. It could have nothing to do with our operation. So they're spontaneously at risk for congenital heart block, congenitally complete heart block. So again, there's a lot of issues with this type of heart disease that makes it extremely complex, and we do what we think is right for an upfront risk to try to have this hope for a long-term survival. But it's a big risk. Now, in terms of timing, we were talking about a patient who was not repaired early. There are a couple of reasons why a child might have not been repaired early. First of all, if you have just the right amount of pulmonary stenosis, despite the fact that you have a big VSD, you won't get pulmonary overcirculation. This will just be like a 10. If it's balanced perfectly well, that child could go indefinitely. We have adult 10s that we repair, you know. They're balanced just right, so they're not too blue, but they protect their lungs because they don't have tons of overcirculation. Why do anything? Because you think, geez, especially if you're a surgeon in a smaller center, I don't really have a good option for this child. I just leave him alone until he tells me I have to do something. But if you don't have a PS and you've got a wide open VSD, that's like not repairing a large VSD in anybody. That's bad. Your lungs will eventually show changes that reflect elevated pulmonary vascular resistance. So you can't just leave that kid go forever. But some children will have just the right amount of pulmonary stenosis. The other thing is that in this particular case, one of the complicating factors was that it was a restrictive VSD. So it's not the big, huge VSD that would be easy to baffle over. And you have PS, so you know you can't do a double switch. So you're going to have to do outstanding Rastelli. That decision making can be very difficult. So this was at a different institution. It had nothing to do with us. So I don't know what their thought process was, but I can tell you this kind of complex intracardiac repair, they're just not going to do at your average cardiac center. And so if they were going to hold on to this child, they may have thought, well, he looks okay now, he's perfectly well balanced, we don't have any great options for him, let's wait until he does something to declare himself. The most likely thing he's going to do to declare himself is develop severe tricuspid regurgitation, which is just what he did. Now your hand is pushed. See, before if you thought, well, we could have just closed the VSD and maybe patched out the PA, leave the RV in the systemic circulation. It's not perfect, but so what? You now don't have that choice, because you'd have to replace the tricuspid valve, because it's now your systemic AV valve. So we're trying to prevent, and it's failing, and it's getting bigger, it's dilated, it's not functioning well. You now need to take it out of the systemic side of the circulation. So you don't really have two choices. You decide up front you're going to do a transplant, or if you have the technology and the skill set, and you're used to it, which we are, you go for this. But you're doing it now because you're pushed, not because it was elective. Do this at 3, 4, 5 years of age, the kid looks fine. I'd say one of the most difficult things about this operation, though, is you're always taking a kid who looks just fine. Who's running around, the parents are thrilled, it's growing, it's thriving, it looks fantastic, and you're going to put him through this huge operation, which may in fact kill him. I mean, the mortality for this is probably 5%, which is way higher than anything else we do. And the morbidity is also very high, because you've operated on each of these different chambers, which means that post-operatively, you guys have seen these. These are the kids with low cardiac output, high CVPs. We're trying to protect their brains. At the same time, we're trying to get them through the operation. They have a lot of arrhythmias. It's a very, very difficult patient management challenge. So, in this particular case, I think that unfortunately, the other institution may have waited a little longer than we would have liked. Where now we were pushed because the right ventricle was failing, the tricuspid valve was failing. The real only options are going to be a transplant or this. And if this works, you're going to be really happy with it, because they'll take that volume load off the ventricle immediately. The LV will start to work well. So that's one challenge. The other thing is that if this is not, if there isn't enough PS, or if this VSD is not large enough, remember that LV starts to get what's called deconditioned. In other words, it needs to be under systemic pressure to be able to then put it to the aorta. If it's been under less than systemic pressure and you put it to the aorta, it fails acutely, like in the operating room. So that's another challenge, is to try to make sure that the kid is well prepared. It's called preparing your ventricle. That's sometimes why we ban some of these kids, because they don't have enough PS to develop an LV that's under systemic pressure, so that then when we switch them, they can tolerate it. So this is about as complicated as you can get, both from a sort of management perspective, a pathophysiologic perspective, and then a surgical perspective. Well, so now we've gone and in trying to do the right thing, we now have put a tube from his right ventricle to his lungs. We now have closed the VSD with a patch, so septum, mostly there's probably patch. His LV, which was under low pressure and a relatively low resistance circuit, we now put it to the aorta through a restrictive hole, right? And we've done the most complex intraatrial baffling you can possibly imagine, where there's Gore-Tex sitting in the middle of his atrium trying to redirect the systemic venous flow this way and the pulmonary venous flow this way. So it's got no compliance in his atrium either. You give him volume, I bet his CVP just goes, you know, and his pulmonary arteries see that same pressure, he starts bleeding from his endotracheal tube and all that. You know, that's sort of what we're left with. So then the challenge becomes in the post-operative period. Inevitably, these kids will be in low cardiac output, and they'll have low blood pressures, and you give them all the steroids, you give them all the inotropes. The most important thing from the intensivist perspective is you have to maintain cerebral perfusion pressure. Cerebral perfusion pressure is the difference between your CVP and your mean arterial pressure. And it's even more challenging the older the patient is. You can get away with a lot in babies, you can't get away with it in older kids. But you need to have that number at least 35. So if you had a CVP of 25, which would not be unusual in this, you have to have a mean arterial pressure of 60 to maintain a cerebral perfusion pressure. And I bet you could not get a blood pressure, probably systolic of 60 in this guy sometimes. I wasn't there, but I'm just guessing. So what do? Put him an ECMO. That's all you can do, and you try to take off a ton of fluid, and you hope that his heart starts to adjust to this new physiology in a time period that is going to be helpful to him. And, you know, they were able to do that, but then they couldn't get his chest closed. So then they had to figure out, you know, how do we get his chest closed? And every single time they tried, they were dealing with low output again. Why? Because you got this big conduit coming in here. You have the vortex in his atrium, which if it gets compressed, doesn't fill his heart. He's got an underfilled heart, so even if his systolic function is good, his diastolic function is terrible. You know, these are the things that you're challenged with. So now, you still have a couple options, but you're further out. One is, you get off ECMO, and he has adjusted some, and you've gotten his fluid status in a better state, and he sneaks through and he has no CNS incident. That's the highest risk, is a CNS incident. Or you decide you can't do that, and then you got to transplant. And if you're going to end up transplanting a 13-year-old, that means you're probably going to go to a 5-VAT before you're going to go to transplant. You're not going to transplant the mechanism. It's too risky. Too much bleeding risk, too much clotting risk, too much infectious risk. So I think that's pretty much where we are. But
How much time will we have to adjust?
as long as we give them.
Right, but how?
You know, I mean, these things, even when you close a VSD in somebody, their heart remodels for months, 6 months to a year. So, you know, if they have some systemic ventricular dysfunction or something, I said, as long as you can get off a ventilator and keep moving forward, it is what it is, and we'll look again in 6 months and we'll have a much better idea of if there's any residual problem or not. Something like this, I mean, for his filling pressures to fall, I mean, it could be months from now. The question is, can we get him there, you know, before he runs into a complication or something else?
I missed a little chunk, so forgive me if I didn't ask a repeat thing that you already mentioned, but, so, we went into this knowing this was gonna be a really big procedure, and the hope was that we wouldn't be at the point that we're at now,
Correct.
right? The hope was that it
You
would.
knew he was going to be very, very sick.
It was gonna be sick, but it would do the job, and then, if, let's say this hadn't happened the way that it did, the projected outcome for him would have been what?
Well, the projected outcome would have been that he would have had the chance to live a long, full life without systemic ventricular failure.
Okay, which was the goal.
Which is the major thing that you need to do when you have a systemic right ventricle with a failing tricuspid valve.
Okay,
So, like I said, at the point that we were doing something, we were pushed.
right,
At the point in which we sometimes do something at 5, 6, 7 years old, we're doing it to healthy kids with the idea that we've explained it upfront to them,
right,
with the idea of a long-term benefit.
better
And this is
outcome.
really, this is one of the very difficult decisions because the upfront
Right.
risk is significant. The long-term benefit, we think, is a long, full, normal life. Now, him, the best you could hope for is he has a bunch of RV to PA conduit replacements, which is gonna have those forever. But it might be 10 years or so until he's done
Right,
on the pulmonary side.
okay,
So that's the challenge. I think in this case, it's a little bit more clear cut because his right ventricle was failing at severe TR. You had to do something. And the only other option is transplant. And I'm sure that was explained to him. I'm quite sure. Because it's still not taken off the table, right? It's still an option.
right,
And we would have said that. We think this is a better option. We've seen kids who've gotten better once you unload the right ventricle and the tricuspid valve starts functioning better. If we can get him to this operation, he's going to be much better than he was. If we can't, then we have to talk about transplant anyway. I'm sure that's the way it was presented.
okay,
But in many of the kids, when we're doing this, same exact kid, but not symptomatic, right ventricle not failing, tricuspid valve leaks a tiny bit, but not a ton. We know what the natural history is going to be. So we're trying to find a time when we think the child's old enough and big enough to do this complex operation. And that kid's coming in totally healthy, almost 9 times out of 10.
okay.
And that's a real tough
Did
one.
not come into
You know, that's a real tough one because that's, you know, and you're telling parents that I'm going to take your healthy kid and I'm going to make it much worse before they potentially get better. But yeah, so he'll still need RVPA conduits. He'll still be at risk these atrial switches in anybody are at risk for stenosis of various pathways, so I was looking for that. But mostly what we need right now is we need his ventricle to relax. Because the ventricle squeezes, but it doesn't relax. And so he's got diastolic dysfunction for the most part. Make sense? It takes time. This is huge inflammation. I mean, everybody you see here has diastolic dysfunction post-op. This is all the effects of cardiopulmonary bypass. Contacting foreign, he's sitting on ECMO, so his blood is contacting the foreign surface all the time and just reinvigorating an inflammatory response. Can't artificially make what wasn't intended to be futzed with, So.
And then how's his LV?
How's LV?
Yeah.
His LV systolic squeeze is okay, from what I understand. It's not perfect, but it's should be good enough for him to come off ECMO. The things that keep him from coming off ECMO right now, I think, are more about the diastolic function of his heart. So you got to be able to relax to accept blood to then be able to squeeze it out. And if it's stiff and doesn't relax well, can't fill it well, you can't get good cardiac output.
So afterwards,
Not much you can do for diastolic dysfunction other than time. We have no magic drugs.
oh, that's right.
So systolic function, dysfunction we treat all the time. Not much for diastolic dysfunction. Other questions? Make sense? Sort of?
Okay, thank you.